It's my proud privilege to stand before you, and I thank Dr. Kumaravel for giving me this opportunity to be a part of the great Trendo 2015. The topic given is glycemic management in diabetic nephropathy. I will go about the following order. So initially deal with the epidemiology of the condition, then go about how kidney contributes to the glucose homeostasis, then deal with the CKD stages, and go on to deal with the issues with glucose control in diabetic kidney disease. So technically now the new terminology for diabetic nephropathy is DKD. Nephrologists would prefer to call it DKD. And renal replacement therapy, different issues related to glycemic management, and go on to summarize and finally discuss few case scenarios also. So if you see, this is actually a snapshot of pie diagram showing the distribution of causes of CKD in the US, but the situation is not different in India. It actually, the contribution of diabetes is much more. The registries in India, it crosses more than 50%. It's the commonest cause of CKD in the present scenario. And we also know that nearly 25 to 30% of type 2 diabetes in their lifetime go on to develop nephropathy. And this ratio, this proportion is more or less similar in type 1 diabetes also. We should know that initially in around 40 years, if we had taken that nephropathy was thought to be a specific domain of type 1. As time went on, so many studies went on to prove that it's much more common in type 2 rather than type 1, and now we have that in both type 1 and type 2 it's equally prone to nephropathy, nearly equally prone to nephropathy. If you see what is kidney's contribution to glucose homeostasis, so it controls the main clearance of the main hormone which controls it, the insulin, and also provides for gluconeogenesis. It also controls the clearance of other factors of proinsulin, C-peptide, insulin-like growth factors, glucagon. It also controls the adipokines, the various chemicals which go on to control the inflammatory state, and also controls the glucose reabsorption. If you see the natural history of diabetic nephropathy, so way back Mogensen had described this as stages for type 1 diabetes. In type 1 diabetes, he had initially described as an initial stage of hyperfiltration, followed by the stage of clinical latency, then followed by the microalbuminuria, that is incipient stage, then the over-diabetic stage, and followed by the end-stage renal disease. So this we can see that progressive initial increase in the GFR, followed by progressive decrease in GFR, and so also the increase in the proteinuria. And also we know that now no longer we use the terms microalbuminuria and macroalbuminuria. There is a change in the terminology. So now that we have realized that albuminuria is a continuum, no longer we classify it as microalbuminuria and macroalbuminuria, and we just call it as high albuminuria and very high albuminuria. So these things will correspond to incipient diabetic nephropathy and overt diabetic nephropathy. If you see the stages of diabetic kidney disease, so classically the chronic kidney disease, or specifically in diabetic kidney disease, when you say diabetic kidney disease, it refers to kidney disease in a diabetic. So a person can have kidney disease, can have a diabetes and also a non-diabetic kidney also. So that doesn't come under diabetic kidney disease. So if the stages, it can be divided into 5 stages. The first stage, the first stage corresponding to more than GFR more than 90, second from 60 to 89, stage 3, namely the moderate category, moderate CKD, which corresponds to 30 to 59, stage 4 being 15 to 29, and end-stage renal disease corresponding to less than 15 ml per minute per 1.73 meter square. So we know this definition of DKD. It's not a moderate. Is actually, when you see DKD here, it's a moderate DKD herein, which corresponds to kidney damage or a GFR less than 60 for more than 3 months, for at least 3 months. The kidney damage refers to pathological abnormalities or markers of kidney damage, which includes abnormalities in blood or urine tests or imaging studies. So, what are the issues with glycemic control and diabetic nephropathy? The issues relate to alterations in glucose metabolism and pharmacokinetics, and also to those related to OHA metabolism and pharmacokinetics, and insulin metabolism and pharmacokinetics, and finally in the monitoring, the effects on the HbA1c. These are the various alterations and the issues related to glycemic control. So what are the prime? Main will be the decreased clearance of the insulin and OHAs, and it will be the impaired gluconeogenesis, and these will lead on to hypoglycemia. And concomitantly, there will be also impaired glucose disposal and impaired and increased insulin resistance. This insulin resistance mainly contributed by the uremic toxins and the pro-inflammatory state, uremic state, and that will lead to hyperglycemia. We move on to the restrictions with diabetic kidney disease. The prime, you know that the first line modality is the metformin. According to the FDA, US FDA guidelines, they base everything, restrictions are based upon creatinine. Actually, anything based upon creatinine will not give the full information. Nowadays, anything is monitoring is based upon the estimated GFR, that's glomerular filtration rate. So if you use this as a cutoff, it will be a very stringent cutoff that will mean to restrict in a large section of population. But nowadays it has been less stringent. Actually, a Cochrane review has studied nearly 247, it's a meta-analysis of 247 studies, and when they nearly analyzed all the studies, they came to a conclusion that there is not even one case of lactic acidosis in all these 347. So this the issue of lactic acidosis due to metformin is overblown, and they have not supported such a stringent criteria for metformin restriction. So in fact, the NICE guidelines, the British National Formulary, goes in for relaxation of these restrictions. For them, accordingly, we can use it with caution with GFR of 45 to 59, and even with from 30 to 44, we can go up to a maximum dose of 1000 milligrams per day, or reduce it by 50% dose reduction. But they don't advise to start a new therapy in this GFR range. Actually, the kidney associations, the KDIGO group, they allow for even going for metformin use even in stage 4, that is with GFR of 15 to 30, and that is only if they have a stable disease. So if they have a stable disease, they even go even at stage 4, they go in for metformin use. We come to OHA restrictions in diabetic kidney disease. The first generation OHAs, namely the chlorpropamide and tolbutamide, are absolutely contraindicated. And when it comes to second generation sulfonylureas, you know that these all the sulfonylureas have a common property of they are having first metabolized by the liver, and the metabolites, there could be active or inactive metabolites, and they are secondarily excreted by the kidneys. So when it comes to glipizide, and all are also highly protein bound and are not easily dialyzable. When it comes to glipizide, the metabolites which are produced after metabolism by liver are inactive. So there is no active metabolite with regard to glipizide. So it could be used even in advanced kidney disease. This is same is the case with glycoside. Glipizide and glipizide don't need much of a modification in advanced kidney disease, just because they produce inactive metabolites. While when it comes to glyburide and glimepiride, they lead on to production of active metabolites. So which means it can lead on to accumulation of these, which lead on to persistent hypoglycemia. When we come to thiazolidinediones, these are pure metabolized by the liver and hence don't have involvement by the kidneys and hence need no dose adjustments. Nevertheless, these per se will have a tendency for increased weight gain and fluid accumulation. Hence, although not leading to accumulation of the metabolites, they are not preferred as an add-on. And when it comes to alpha glucosidase inhibitors, they are also having accumulation in renal dysfunction, and hence it's avoided if creatinine level goes more than 2. We come to the recent drugs, namely the gliptins. So gliptins, we have in mild CKD, we don't have any restriction for the gliptin use. But for the moderate and severe CKD, we have restrictions for all except one, that is the linagliptin, which in contrast to other agents has only 10% excretion by the kidneys. Others have a major 50 to 60% excretion by the kidneys, and as a result, they need at least a dose modification in moderate to severe kidney disease, but linagliptin serves as an exception. We come to other GLP analogs. The exenatide, it also has to be used with caution with the GFR of 30 to 50, and below 30 it's advised to be restricted, but no such dosage adjustment is recommended for liraglutide. But the issue is we don't have much long-term safety data with liraglutide. Once we have still a few years safety data when it comes to liraglutide, and then maybe it can be recommended for use in chronic kidney disease. We move on to insulin metabolism. This we will take it in two paradigms. Mainly with when it comes to endogenous insulin, its main clearance is by the liver, and when it comes to exogenous insulin, it has its main clearance mechanism dealt from the kidneys. You come to insulin therapy in non-dialysis CKD patients. When GFR is more than 50 ml per minute, no dosage adjustment is required. On the other hand, if it gets reduced to anywhere between 10 to 50, we need a 25% reduction to, that is to 75% of the baseline, when there is a reduction of from 10 to 50 ml per minute. And if it reduces to less than 50, we need it to be reduced to as much as 50%. This is, it's in a non-dialytic dialysis DKD patient. So this will give a snapshot of what's to be used at various stages. So insulin being used in all stages, even in those on dialysis. Similarly, the glitazones. Similarly, the repaglinate can be used in all stages. Similarly, glycoside can be used in all stages, but not in those on dialysis. We move on to issues with HbA1c in DKD patients. So when it comes to HbA1c issues, it can have both the paradigms. It's not reliable. So it's not reliable because it can lead on to either false low values or even false high values. False high values is just related to increased carbamylated hemoglobin, which interferes with the assays, and false low is usually due to the increased RBC turnover. There will be increased hemolysis and there will be a reduced lifespan, and there is also additional contribution of this by the erythropoietin therapy. The newly formed RBCs will lead on to shortened, increased turnover and having a false low HbA1c. What are the benefits of glycemic control in diabetic nephropathy? So in diabetic nephropathy, if we have a good control, there will be a block in the progression of chronic kidney disease, but this will not be applicable in end-stage renal disease, and there will be also a reduction in the infection rate, and just because there is going to be less glucose in the urine, the infection rate will come down. It avoids the dehydration because osmotic diuresis is going to come down, and reduces the cardiovascular risk, reduces mortality, and improves the survival. This is the Kaplan-Meier curve comparing the HbA1c control and the survival. So anything having a poor HbA1c is having a poor outcome, while there is a subtle difference between the very intensive control and moderate control. So what are the barriers to glycemic control in diabetic nephropathy? The prime will be the insulin resistant state in the diabetic nephropathy per se, and the frequent hypoglycemias which occur with in diabetic nephropathy is another barrier, and the poor oral intake due to uremia, poor patient complaints and interest, and the multiple management issues with less focus being on hyperglycemia and more attention being paid to the other issues. So these are the many barriers. And what comes to renal replacement therapies and glycemic management, we will come to post-transplant diabetes. So what are the issues? So when it comes to post-transplant diabetes, there are increased hyperglycemia just due to use of drugs like glucocorticoids, tacrolimus, which have very high diabetogenic potential. And up to 40% of kidney transplant recipients will develop NODAT, that is new onset diabetes after transplant, over 10 years. And this is because it influences hyperglycemia, also influences graft survival. So hence that's important. And when it comes to steroid-induced hyperglycemia, steroids will be used in a high degree in these patients. So usually these people will be on an early morning high dose steroids. So if it's a early morning steroids, most probably they will come to have higher post lunch or high pre-dinner. This will be the main defects which these people will tend to encounter, and they will be needing increased doses of high dose of morning NPH or afternoon regular insulin, and maybe the night doses may be kept low to avoid hypoglycemia. We come to issues related to continuous ambulatory peritoneal dialysis patients, those on CAPD. And the CAPDs, the dialysate usually contains high amount of glucose. So whenever CAPD is started, there will be hyperglycemia. So that is with those with high glucose. So high concentration of glucose in peritoneal dialysis fluid is in the dialysate will lead to hyperglycemia, And insulin can be given either as a subcutaneous and intraperitoneal. But giving it as an intraperitoneal is avoided just because of infection risk. And even if it is given intraperitoneal, the amount of insulin we need to give will be very high. So it is generally not preferred. And once the CAPD is started, the glucose levels rises. So what we usually try to go in for carbohydrate free dialysates. So one of them is icodextrin. So but one defect with icodextrin replacement peritoneal fluid is it will interfere with the glucometer readings. So that is also not free of any issues. When it comes to hemodialysis, in hemodialysis patients also the glucose control is very difficult to achieve. This is because of variable insulin resistance and abnormal insulin secretion, and these people will have an altered mean pattern on usually the dialysis days. And in most of these end-stage renal disease patients, insulin may not be even required. If at all they require, they might require a very small dose. And most important factor in all these patients will be the glucose concentration in the dialysate fluid. So what dialysate they use on how much glucose the concentration is there, that will be a much more factor in determining all the levels. So coming to conclusions, so glycemic management in diabetic nephropathy requires fine-tuning. So we target for the best possible glycemic control, avoiding hyperglycemia. Many OHs need to be avoided. Relatively safe OHs in diabetic nephropathy include glipizide, gliclazide, repaglinide, pioglitazone, linagliptin. Insulin is usually the standard of care but needs dose modification as per the glucose levels, and HbA1c may not be accurate in diabetic nephropathy. I prepared some case scenarios, so maybe we can go and maybe I will just take your input in what can be the way in which we deal with them. So if a 72-year-old lady with diabetes is on metformin for 5 years, comes with a profile of fasting of 107 and a postprandial of 227 and a HbA1c of 9.6%. Her creatinine is 1.3 milligram percent. So she is currently on 2 grams per day of metformin. So what are the options? These are the options. What will you consider? You will try to calculate her EGFR. You will continue her medications. You will consider medication change. You will start her on GLP analogs. Multiple answers can be right, so you can choose. So what will you do?
A and C.
A and
C.
Fine. So her EGFR by modification of diet in renal disease formula comes to 33. Actually, using creatinine, we don't actually really calculate the misdiagnose the stage of kidney disease. The real we have to shift our scenario to from creatinine to EGFR calculations. So this is one classic example where just going by creatinine, you will miss the nephropathy in this patient. Creatinine of 1.3 would be taken as of normal, but she is in she comes in stage 3 CKD. So her EGFR by MDRD formula comes to be 33 ml per minute per meter square. So taking this, so now what will you? So the first. So in this scenario, so what will be the medication change you will think of? So there is not going to be one answer right. So there will be multiple options. So what is done for this patient? So our medications were modified. Metformin was decreased to 1 gram per day, and sitagliptin 50 milligrams per day was added. And 3 months later, her HbA1c was 7.8% and was asymptomatic. So this patient chose the option of going to sitagliptin as add-on after modifying the metformin dose. She can go also on insulin. So it's individualization and the patient's priorities. So we go on to second case. This case, message of this case was already given by another Dr. Vijay Bhaskar Reddy. So we will go through it. A 47-year-old man comes from a village with a history of loss of consciousness. He had a type 2 diabetes history for 10 years and has been on glycemic for 5 milligrams twice BD, and his creat is 3.8 milligram percent. His blood glucose is 41%. He gives a poor intake of food. So once in the hospital, he regains consciousness after being given 25% dextrose. So what will be your course of action? So we will advise him, just because he didn't take proper diet, he had hypoglycemia, so advise him on a fixed meal plan. You will continue the glucose infusion and keep him on observation. C, change to gliptins. 4, change to glipizide or glycoside. So what will be your
C and D. B and D. B.
Who all want A? A. Okay. B.
B.
B and B.
Who wants C? No one wants C. Okay. Who wants D? Okay. So B. So what is the rationale behind such bringing up this situation? Glutamate is a long-acting one, and it has an active metabolite, so which will persist in the circulation. So it's not enough if you just correct the hypoglycemia at that point of time. If you just send him off, he might come the next day or the next with again repeat hypoglycemia. So what we need to do is just observe him for a few days. And in fact, so this will be one option, right? And other option can be, depends upon whether he changes to gliptins or whether he changes to glipizide or glycoside will be determined by his financial status. If he can afford, gliptins would be a choice, and if he can't afford, he can go on either glipizide or glycoside. So these will be the options. We go to the next scenario. The 60-year-old man comes with type 2 diabetes with stage 3 CKD on metformin on 1 gram per day and concomitantly on NPH and regular insulin, complaints of progressive anorexia and frequent hypoglycemic episodes following his insulin doses. His HbA1c is 8.4%. So steps to be taken include: stop all the insulins, shift to insulin analogs, shift to full dose metformin, shift to linagliptin or SGLT inhibitors. So who want to stop all the insulins? Who wants to shift to insulin analogs? So what's the rationale behind that? Why you want to shift?
Short acting.
What insulin analog we want to use in this situation? Okay. Glargine. That will serve the basal. Bolus. No mix is a premixed insulin.
Sir, Lantus with the gliptin, sir.
So anything of basal analog and a basal short-acting analog. So that will be a best in him. So this option is we won't be going for full dose if he is in stage 3 CKD, and there is an option that he may go on to linagliptin in this case. We go to next scenario. A 54-year-old lady comes with diabetes with FBS of 212 and a postprandial of 330, and her HbA1c is 7 gram percent. Her creatinine is 2.5 milligram percent and her HB is 8 gram percent. Patient denies any features of hypoglycemia. What is the discordance?
Vastly low
This is a classic situation of false low HbA1c in a CKD. Okay, so ideal would be to monitoring with just a capillary blood glucose, or there are other alternatives. We can the modalities of fructosamine and glycated albumin have been advocated, but those are also have not been standardized. They are also not recommended. The last, this 67-year-old diabetic for 15 years comes with early morning hypoglycemia. This is something similar to, but he is on pre-mixed insulin, not on basal bolus as in previous regimen. He has hypoglycemia for FBS of 452 and a post-meal glucose in the range of 250 to 300 milligram percent. His HbA1c is 9 milligram percent, 9% and creatinine is 3.5 milligram percent. He is on premixed insulin 30/70, 25 and 15 units. How will you proceed in this case?
Basal bolus.
Reduce the night dose.
You should switch over to basal bolus.
Pre-mixed we can reduce to 50.
This again basal bolus will be answer, but again whether if it's analog it will be much better. Here conversion to basal bolus will be option, but conversion to analog insulin will be the best option. Okay. Thank you.